Welcome to this panel on insights on international healthcare and how they reflect on our problems here in the United States. My name is David Blumenthal. I'm president of the Commonwealth Fund. The Commonwealth Fund is maybe unique in the United States in doing intensive cross-national studies in the developed world rather than the developing world, in high-income countries, to understand how other countries organize and finance their healthcare systems and what we can learn from them in the United States. This issue of coverage is gaining traction now especially because of the 2020 election cycle. Next week, we will begin the debates for 2020 with the Democratic candidates. There will be vigorous debate among Democratic candidates on the way to proceed with respect to our healthcare system. That's a teachable moment in our national politics, and healthcare is clearly one of the major issues on the minds of the American public. Polls show that it is first or second as an issue that the public feels the government has to address. The Commonwealth Fund every couple of years issues a cross-national ranking that looks at 11 countries, including the United States, in terms of the overall performance of their healthcare system. We look at dozens of measures of cost and quality and access, the whole range of performance metrics. The United States routinely ranks last, and we have here today representatives of two of the three countries that lead the list. Those three countries are Australia, the Netherlands, and the United Kingdom. Just to give you an example of the difference between the United States and, for example, the United Kingdom, the United Kingdom spent in 2017 a little over $4,000 per person on health care, when the United States spent a little over $9,300 per person. But the United Kingdom had better healthcare results as judged by preventable mortality that's preventable by healthcare in our healthcare system. So twice the spending in the United States and lesser results in terms of healthcare outcomes. I'm delighted that we have our two guest panelists today. They have come literally from across the ocean, probably by a polar route, I would imagine, where it was even colder than it is here. And on my immediate left is Jennifer Dixon. Jennifer Dixon is the head of the Health Foundation in the United Kingdom. She's also run other foundations there. She has served as an advisor to the National Health Service and is a perennial expert on the United Kingdom and on other healthcare systems. She's also a physician with a PhD to go along with it. And on her left is Marit Tanke. Marit also is a physician with a doctorate. She is the head of strategy and innovation for a private health insurance company in the Netherlands. We're going to hear that not every country that insures and covers everybody does so exclusively through public means. In fact, the Netherlands relies heavily on private insurance companies. Marit, as I said, heads strategy and innovation for one of those, and has also worked both in the academic sector and in the public sector in the Netherlands, and has a broad experience with the Dutch healthcare system. I also have to say that both our guests are former Harkness Fellows. The Commonwealth Fund every year brings about 15 health professionals to the United States to spend a year here studying our system and comparing it to their home-based systems. And both of these individuals are graduates of that program, and we're delighted to be able to share their expertise with you here today. So why don't we start with the United Kingdom and Jennifer, and then Marit will talk briefly. We'll then have a conversation between them, and then we'll open the conversation to to the audience.
Thank you. So thank you, David, for those lovely warm words, and it's very nice to be here. I'm very thrilled for the opportunity, so thank you to the Commonwealth Fund for that. My first time in Aspen. So just to say a little bit about our system in the United Kingdom. So I think you know we have the National Health Service. We set it up in 1948. There has to be a feel-good factor here for America because there is a question about whether we would have been able to set it up had it not been for Marshall aid. Your country very generously gave to us and other European countries to rebuild ourselves after the war. So there was an enormous sort of public groundswell of opinion, the spirit of 45, as it was said, to try to correct some of the ills of society because everyone was thrown together in the war. And that had a number of effects, one of which was to produce a massive groundswell of support for a national health service. At that time, just a couple of other historical words, is that we did not have a very strong system of insurance. We had a patchy, failing system in our country, and there were no large lobbies except for the doctor lobby to stop what was otherwise going to be a pretty strong social program, including to set up the National Health Service. Anyway, today it's going strong. It tops the public polls for satisfaction. It tops the public polls for the issue that the public hold most dear. As I say, satisfaction is very high. How does it work? There is universal coverage. Everybody in the country is covered 100%. The benefits are comprehensive. There's a bit around the edges that I'll come to talk about. There is no co-payment, no deductible, no bill of any sort. I've used the health service. I've been a doctor in the health service. Never have I issued a bill. Never have I ever seen a bill. That doesn't happen. There is no insurance policy that you get in the post to say what's covered and what isn't. It's just like an unwritten constitution. There's nothing to renew, nothing. It's just all there and it's free. And it's also free to people who are ordinarily resident in the UK. So if you came to live in our country and you were working there, then of course you would have access too. How do we do it? Well, we pay for it by taxes, as David just said. We're cheap. The $4,000 actually per capita includes a small amount of private insurance. So the NHS is even cheaper than $4,000 per head. It's almost all of it is tax funded with a tiny amount of, there's a little bit of co-pay for prescription drugs, which amounts to £9 per prescription. And even that is capped at £30 per quarter. So really it's like nothing. In the country, about 10 to 11% of the population do have private health insurance, but typically most of that is through employment. People don't actually go actively out and choose, and that covers a small proportion of elective care. It doesn't cover emergency care, it doesn't cover primary care, for example. How do we contain growth of costs? We have a global budget, and that's it. And the global, effectively, the government keeps a lid on it, and its costs are performance managed in the system. And the growth has been roughly around, well, since the NHS began, it's about 3.7% real terms growth every year. In austerity, it's been closer to 2% real terms growth, so the pips have been squeaking in the NHS over the last 10 years in particular. We regulate prices, so doctors are salaried, not GPs, but all hospital doctors are salaried, and there's no fee for service in that domain whatsoever. There's a fixed, the prices for drugs are closely regulated as well. The cost of services in hospitals is regulated. There's a DRG payment with a fixed national tariff. So we really try and get our arms around all those costs. And furthermore, we also have quite a lot of regulation, which means that we look at fruity variations in use rates across the country. For example, prescribing rates. There's no way you could have a kind of fee-for-service pill mill or whatever going on in the country because it would be noticed. The NHS owns all the hospitals that we've got. We've got 235 facilities, 135 acute trusts, 7,000 or so general practices. The general practices are not salaried by the NHS, they are private employees, but they are monopoly suppliers, more or less, to the National Health Service. So I think, in short, it's one system, it's one payer, you can get your hands around the costs, and you can do a number of things to regulate cost control. to regulate costs over time, and that's been highly successful, probably too successful actually, because we're very cheap, as you see. But the last thing I would say is that quality is okay, it's good, it's middling in some areas, it's not as good as where we would like to be, but I would say across OECD nations it is middling, but certainly we exceed in some areas, as David said. So I think the bottom line is that it's a very, very valued and loved service by the population. I'll leave you with one anecdote. We had our 70th anniversary of the NHS last year, and 2018, and there was a church services throughout the land as people gave thanks to the National Health Service, and I was at the one where the chief executive of the NHS spoke at Westminster Abbey in the pulpit about the service, and at the beginning of the service, the National Health Service, with the little piece of paper which had the National Health Service Act on it, the 1948 Act, was brought on a velvet cushion up the aisle, which others have remarked upon. So I think that shows you it's very special, from a duke to a dustman, everybody, it really appeals to the sense of fairness and there's widespread political consensus across rich and poor in the land, and it's a very loved service. It's not going anywhere anytime soon, it's just hopefully going to be developed. It's okay, it's good, we all love it. I don't have private health insurance, neither do my colleagues who are professionals like me. I don't know anyone. People perhaps in the private sector do use it to bump a queue. We can talk about queues later if needed, but it's fit for purpose for us. Still needs to develop, but we're happy with it. Thank you.
Thank you, Jennifer. Marit?
Yeah, thank you. We don't adore our healthcare system the way that you do in the NHS, but still I think we have a pretty nice system with lots of innovation, almost universal coverage. But first, before going into that, I'm really happy to be here as well, and thank you for the invitation, and thank you all for being here, and the opportunity to discuss healthcare systems with each other. I was a Harkness Fellow 2 years ago, was in Boston. I did a cross-country comparison of high-cost patients in 7 different countries, and through that project, I truly experienced how powerful it is to discuss, to talk about the different healthcare systems, differences, similarities, and really deep dive into your system or the other system, and then find out what may or may not apply to you and what you can use to improve. And so I hope to give you a little bit of the Dutch system today on your path to universal coverage. Our system, our healthcare system, healthcare and welfare system in the Netherlands is based on 3 acts. The Social Support Act, which is run by municipalities, and it covers activities for people that help people live independently. So it could be daycare for day activities for elderly people who might be lonely, or it could be something like a chairlift in a house to help people to live independently. Second act is the Long-Term Care Act. That's to deliver care for people who really need 24-hour-a-day care or support. So people with severe dementia, for example, who cannot live independently anymore. And then the third main act is the Healthcare Insurance Act. Healthcare Insurance Act covers all medical care. And that's where I'll be talking about today, because that's my world. It covers all medical care, so that means hospital care, primary care, mental health care. And it's as David already mentioned, it's a private system. But it's a private, not-for-profit system, and it's heavily regulated and managed. It's based on solidarity, and our key principle within the system is based on managed competition. So we believe that managed competition between this private, not-for-profit payers and providers, together with patient choice, drives the system towards high quality and low cost care. And in this system, there is a pivotal role for the insurance companies. So I work for VGZ. It's the second largest insurance company of the country, 25% of market share. There are 4 large conglomerates who together have about 90% of market share. And in our system, these insurance companies have given the role to provide accessible, affordable, and high quality care to our beneficiaries, or members, as we like to call them. And the government, they safeguard from a distance. So they set the rules and regulations that are needed to provide this level playing field. And then they say, well, now it's up to the providers and the payers and the patient to work it out and create the system together. It's covered partly, the system, so the Healthcare Insurance Act system is covered partly by premiums. People pay monthly premiums to the insurer or the health plan of their choice. And then partly it's based on income taxes through the employers. On the coverage side, there are a number of regulations in place to ensure that people have coverage. So first is our benefit package. We have a very broad, basic benefit package. It includes almost all medical services, except from some services like very experimental treatments or physiotherapy for people not having chronic conditions, or dental care for adults. For those treatments, if you want, you can buy additionally a voluntary insurance. We have at the moment 99.8% of people actually have a health plan. It's mandatory, so you have to have it. The reason that it's not 100% is because we have a small group of people in our country who, for religious reasons, don't want to have a health plan. And there's a small group of people in the army who have their separate system. But otherwise, 99.8% of the people. So it's mandatory to buy a health plan, and insurance companies or health plans also have to accept everyone who buys a health plan with them. So you're not allowed to differentiate or not accept people based on age or pre-existing conditions or something. And we're also not allowed to differentiate premiums based on age or other conditions within a health plan. To ensure solidarity and this level playing field, amongst others, we use this risk equalization scheme. So all the money that comes through the income taxes goes to a healthcare insurance fund, and that money is distributed to the different insurance companies based on your population, so how sick or not your population is, and how many children or non-paying beneficiaries you have, for example, children under the age of 18. And then for the individual, how do we ensure affordability? Well, one of the things is we do have a deductible, but it's capped on about $450 per year. We have copays. If you go to an out-of-network provider, there are copays, but that's only for non-emergency care. So emergency care, you can go everywhere. And the copays are capped on about 20-25% of the costs. And then we have subsidies for people with low income for the monthly premiums. Cost containment, how does that work? We have maximum tariffs for some services, like acute services and more complex services. We have maximum tariffs. For the other services, we rely on the negotiations the contracts between the payers and the providers. And as insurance companies, we really try to get the lowest premiums possible because that's how we attract new members at the end of the year. So, and the lever through which we can do that is good contracting. So we really try to get the best contracts with the providers, and we contract on price and volume. So basically, we contract budgets with the main providers, and we really try, well, new innovative ways to do that through payment reforms, but also we now started partnerships with a number of providers to see if we can change the way that care is delivered, especially if we can lower volume, unnecessary procedures, and thereby lower the budgets that are needed. And then the last main thing in this cost containment issue is that since 2013, there are voluntary agreements between the government, the payers and the providers, in which we agree on a very moderate increase in healthcare costs. So it started about 2% per year, but we're now at about 1% a year, and we have agreed with each other that in 2022 there is 0% increase in volume in healthcare anymore. So that's voluntary agreements where we agree on. However, if we don't follow the agreements, there is a backstop, and that's that the government can set a budget to the whole healthcare sector. So a bit different from the UK, but that's how it works.
Terrific. Thank you so much. So a lot of the questions that Americans have about other countries' health systems, especially those that are single payer, have to do with accessibility of services. And the story is that in these other countries, people wait a long time to get to see a doctor or to get admitted to a hospital, especially around elective procedures. Could you comment a little bit about waits in your systems for routine and non-routine care?
So in the National Health Service, we have national targets for waits, and there's an 18-week wait for elective surgery, and the target is, I think it was 95% of people should wait no longer than 18 weeks. We have not achieved that target. It's in the 80s, but that's certainly a lot better than it used to be, I would say 20 years ago, where we had no targets for elective surgery. We also have maximum 2-week waits for cancer referral and cancer care. So these are very strictly monitored and checked upon, and so I think relative to where we were, we are doing a lot better, but that's the situation. Not also forgetting that in the UK, you cannot take yourself off to a consultant straight, a specialist. You can't just directly refer yourself. You have to go via the general practitioner. So I would say that that's the order of wait in the UK. It's certainly not years, although there are some very long waits, but there may be particular reasons for that.
Yeah, a bit the same in the Netherlands. We also have a system where you have to go through the primary care doctor, so the GP first, before being referred. Generally, you can get an appointment with the GP within 1 or 2 days. For specialist care, we have norms around 6 to 8 weeks, depends a little bit on the condition. Oncology is also around 2 weeks. And those are monitored. And yes, we do have waiting list for some specialists, but generally accessibility is quite good.
That's one more thing.
Yes.
So sorry. Another aspect of access is not waiting. It's actually whether there are certain services that are just, you can't actually that they are rationed in some way, or more obviously rationed. And I think there are some areas, such as I think you mentioned dental care, where it is, I mean, it's very, very difficult at the moment to find an NHS dentist. It's almost impossible. It is, so dentistry is one area. Obviously, optical care, optician care, that's another area which is, there aren't free eye tests any longer, and something called continuing healthcare. That's where care is on the margin of nursing stroke social care. Social care in Britain is means tested, which you have to have a certain level of income above which you simply cannot, or a certain level of assets you cannot access free or at least government-funded social care. So some things on the margins, also cosmetic surgery, we obviously don't offer that blanket on the NHS. In vitro fertilization, there are some limits as to how many attempts you can have. So that's another aspect of access. That's true in every health system, but just to say that's made explicit. Made it explicit for all.
So one of the, full disclosure, I'm a primary care physician. So primary care matters to me, but it also matters to the American public. Most people want to have a, quote, family doctor, or at least a family provider. May not be a doctor, could be a nurse practitioner. Say a little bit about the primary care systems in your countries and how they're organized and how they're financed.
Okay, so in the UK, we've got a very strong system of primary care historically. Everybody is covered by a general practitioner. So, for example, where I live, I've registered with one, and I'm likely to be there for the whole length of time I'm living in that location. There is a choice. You don't have to go to the local one. You can go, there is a choice, but most people go to the local one, I would say. It's a strong system. We have all primary care, the route to hospital care is via primary care, so you get to see your GP a lot. There are about 4 visits on average a year that people make to the general practitioner, that's the average. Lots of, general practitioner is not a one person in an office. It is a multidisciplinary team in group practice. And some of the moves in the UK are to make these, to link up these practices more. So instead of being large corner shop operations, they are more professionalised, larger entities with professionalised management that can oversee the care and to build in quality control a lot more effectively. It is a very loved part of the service, I would have to say. People often register with the GP for their life if they don't move. The GP knows the family, they know the context, and therefore the GP is very well placed to understand a little bit more about what's holistically affecting the health of an individual, not just the one transactional issue that the person goes with. And that's particularly important for chronic disease, mental health care, for example. So it's highly computerized and very, as I say, very, very popular.
Good.
Yeah, a lot of similarities here. We also have a very strong primary care system where the primary care doctor, physician is the entrance to the healthcare system. Also here, it's mainly locally based. People do tend to go to their local GP. There is a choice. And also here you see that the primary care practices in the last couple of years tend to change from like this holistic practitioner to like this multidisciplinary team. We have a lot of policies in place where we actually try to get more and more treatments and procedures out of the hospitals into the community with the primary care team. And we are working on strengthening the primary care team to do that in a number of ways. So for example, since a couple of years, almost every primary care practice has a specific nurse practitioner for mental health. And they work with the primary care practitioners to see those patients who have mental health issues before referring them to specialized mental health clinics, for example. And so they also have nurse practitioners working in primary care for more physical complaints, chronic diseases like COPD, diabetes, and the primary care practitioners are more and more also working with the community teams, the community nurses, to have like this holistic view and provide integrated care at the primary care level. You ask about funding. It's funding for primary care practitioners is about 75% is capitation. So people describe with a primary care practitioner, and the physician gets like a fee, a capitation fee for those patients. And then the other 25% is based on either specific procedures that they do, or they get a bit more money if they're more heavily involved in organization of like community infrastructure, or maybe if they are in a certain population where, in a certain neighborhood where the population is a bit more difficult. But also we are doing projects with primary care practitioners and hospitals in which we provide primary care practitioners with more time and more resources to actually prevent referrals to secondary care. And we do see that in those areas, referrals to secondary care actually decline with about 20%. So it's a really powerful system. Yeah.
And just say a little bit about after-hours care in the Netherlands.
Yeah, after-hours care is arranged by the primary care physicians. So also after hour, you can go to your primary care physician, don't have to go to the emergency room, although in most areas, the after-hour care by the primary care physician is now organized into, on a local level, into teams of care. So it's not the one GP who's doing all the care, but it's organized in teams where they do it together.
But there is access to a primary care physician 24/7.
24/7, every day a week.
Okay.
Yeah.
And it's the same in the UK, almost identical, with the same move towards integrated care, multidisciplinary teams working in the community with telehealth, telecare to support all that, just as you say. And we've also got NHS 111, which is a phone line which you can call for advice, out of hours or in hours, and also an online service where it can help to check symptoms. We've also got a beginning of, I don't know whether you've got this in Holland, where you have symptom checkers now on your phone, or at least we're trialling this in primary care. So the first call of primary care is through the phone, and that's something I know the Swedes have been very advanced. We also are beginning to pilot this, so we'll see how it works. It's very popular with young people, not so much with older people who've got this thick notes and chronic diseases.
Yeah.
Terrific.
Yeah.
Okay, I think we've got a picture now of these alternative health systems. I assume that everyone in this room has some understanding of the US healthcare system by comparison. So let's open it now to questions. Yes, over here.
So, yeah. Oh, thank you.
And please identify yourself when you ask your question.
I'm Padmini Parthasarathi. I work for the Walter and Elise Haas Fund in San Francisco. One of the challenges in the U.S., especially if you're working with lower income patients, is, and you spoke to this a little bit around all of the other needs they have in their life, their kind of social needs. And I think there's more of a movement to address that in medical care in the U.S., but one of the challenges is there's no payment for that, for doctors to spend time or nurses spend time making those referrals or providing like case management or sometimes health education services. So I was curious in your systems how that works.
Some practices have set themselves up to be community hubs and bring in workers from outside, social workers, other benefits advisors, things like that, housing advisors. There's some examples of that. There's also examples of social prescribing, where the doctor or person in the surgery, the general practice, is prescribing things on the NHS, such as exercise, gym classes, or whatever. So that's also important. We fund, a bit like in the Netherlands, we give practices more money if they are serving more deprived populations, so automatically there's an extra premium there. And the other thing I'd want to say is that the NHS is now discovering what it might take to be what it's called an anchor institution, whereby the public assets in a place could be leveraged more to help support the health of the local population through employment, through procurement, for example, through using the physical assets of the buildings a lot more. And there's much more interest, and also with climate change too. So I would say there's quite a lot of movement there, but I think it's also true to say that in our country, general practitioners are really, really under the cosh in terms of being very, very pressurised in terms of work. And it's been a big issue to try to get the big tides of funding out of the hospital system and supporting. And we now, going forward from now, have a system where have a plan at least to try to have differential growth towards primary and community services and mental health in favour of those, as opposed to hospital care that otherwise is obviously sucking up a lot of demand. But then you have to have very effective what's called demand moderation techniques, such as integrated care, and whether or not that's going to be able to substitute is a big question. We've been looking at your accountable care organisations. We are developing things that are very similar, called integrated care systems, and we shall see whether they are effective to moderate and prevent avoidable demand on hospital care. So far the signs are that they are weak, not yet strong, but we're still in the foothills.
Yeah, and for us, we're working on this because in the beginning I told you there's 3 different acts and there's 3 different systems, and so our social support system is basically another system than the healthcare system and the long-term care system. Long-term care and healthcare, they're executed both by the same insurance company, so they're a bit closer. But what we see is that our social support system, which is based in the municipalities and is quite strong actually. However, we are now really trying to integrate that system with the medical system to prevent medicalization of these social issues, but to see if we can get the patient or the client on the right place with the right provider. And so what we try to do, amongst others, is to have these community nurses work very closely with primary care practitioner in the same primary care practice, and to see if we can if that works, to get the patient into the social system if they need it. And on the other hand, we're working also with the long-term care system and the medical care system, so that if a patient is in the medical care system, but you see that the type of demands or the types of questions are not really medical anymore, but more support is needed, that we can actively transfer this patient from the one to the other system and make sure that the needs are met. But it's really interesting because I think for the integrated part, I was here in the United States studying the Accountable Care Organization. I think for the part of integration, you're actually maybe a bit ahead of us because you're kind of building this all into one system, and we started with the 3 systems and now try to integrate it. And that's not always easy.
Yes, back in the corner.
My name is Bill Cassidy. When I read about the Netherlands a few years ago, what intrigued me, and you may have spoken to this because I had to step out of the room, what intrigued me is that the beneficiary would get a differential payment amount assigned to her if she had a comorbidity. So there was a little bit of money, extra money given to diabetics, and insurance plans therefore would market themselves for a diabetic-specific plan with outcomes being judged. Now, we have a little bit of that with our Medicare Advantage special needs plans, but I didn't know if you still did that, and if that has been successful. And the idea, of course, being that if you specialize in diabetes, you get better outcomes with diabetes. So could you speak to that, please? Yeah,
so we're trying and we're experimenting. So we have a number of experiments in place. One is the bundled payment for diabetes, for example, but that's not really insurance specific, but that's a very interesting concept in which we have these bundled payments for diabetes care, where also the primary care provider gets a bit more money to organize diabetes care within their practice with this diabetes nurse and like the whole organization around it, we see that that actually improves quality of patients with diabetes and reduces referrals to the hospital because more is managed in primary care. Regarding the health plans specific for diabetes, we do have a number of health plans that are specifically for people with some chronic condition. So we, for example, partner with the patient organization of patients with kidney conditions. Kidney disease. So if we can see if we can design a plan that meets their needs, and we also have that with the Diabetes Association. As for now, I haven't seen any real outcomes for that yet, but this triggers me again to go there and see, hey, what was the outcome? What I know is that in those plans, we basically see, like, are there specific type of services that patients with diabetes might need, and it's more in the voluntary insurance package. It's not in the basic benefit package because that's the same for everyone, but then we can differentiate a little bit in our voluntary insurance package. Yeah.
Yes.
Me?
Yes, you.
Yeah. My name is Michael Chetta.
There's a mic coming.
Thank you. My name is Michael Chetta. I'm an emergency physician. I oversee integrated care for U.S. Acute Care Solutions. And my question is two questions, if I may. First of all, to David, is there some explanation for the disparity of 9,800 in the United States and 4,000 in the United Kingdom that is explained by perhaps the population we have in the United States, where 10 to 15 times as large? There's other reasons other than the kind of the foundations of fee-for-service versus non-fee-for-service. And then the second question is, what portion, I'm always stunned by how much money we spend in our company for the non-direct expenses related to a visit. Coding, billing, and all that kind of stuff, the back end, that contributes nothing to the patient's care. So in the United States, it's 25 to 30% of a visit, of a healthcare dollar goes to non-patient care related crap. And so what's that, what's the ratio in the United Kingdom?
So perhaps I can answer that. It kind of, I saw that the Wall Handler Himmelstein paper, which looked, and it kind of depends on how you count what you define as administrative costs. The study that I quoted is one by the OECD that looks at administrative costs across where there is at least some comparison in terms of definition. And we spend 2 pence in the pound on administration, like really low. And I know that Germany is 5 and France is 6 pence in the pound. Now that cannot be the same comparator with you, because yours would be 30% and the 30p in the pound, as it were. So there must be some definitional issues, but clearly in our system, no payers. We do have coders, but there's no bill, so it's going to be a lot lower. So at the moment, our admin costs are really quite low, I would say.
Yeah, I know in general from the study that those countries who have like a multiple payer system, those administrative costs are higher than those with an NHS. I know ours are lower than the US, but I don't know the exact percentages.
So I'm not going to take a lot of time, but I would refer you to a book called Priced Out by Uwe Reinhardt. Uwe Reinhardt is a very well-known economist who actually is German by birth, but lived in Canada for a while before coming to the United States. His hypothesis, or his contention, as you can tell from the title, is that it's the prices. Yeah. He actually wrote an article earlier in his career called "It's the Price is Stupid." What we don't use more care in the United States than the UK or the Netherlands. We just pay much, much more for it.
There was a quote I just heard, Andy Slavitt on one of the, said that a vial of insulin here was $400 per vial. The same vial in Canada was $40 per vial of insulin.
John?
Thanks. Hi, John Pearl at HCA Healthcare, and I used to run the VA health system. Let me thank you for terrific insights. You've had the privilege of being Harkness Fellows and seeing our system. Obviously, you know your own very well. And it's been reported that we have a presidential election coming up. Were either of you elected president? And congratulations. And your mandate were to increase access and do what you could to control costs. What would be the top one or two things that you would see as essential toward affecting that platform?
That's a very unfair question, John.
Yeah.
I heard the job of president being described once as every 15 minutes someone brings you a problem that no one else in the country has been able to solve. So this may qualify as that, Jennifer.
Always dangerous to comment on someone else's healthcare system. Well, I think you've had it right. I obviously think price control is a critical one. Drugs, fees, the whole fee-for-service currency is just, I mean, it seems like the Wild West to us, if you don't mind me saying that. This is the Wild West here. You know, that builds up sort of horrendous incentives. And then clearly on the coverage side, you know, you will find your own path to some kind of universal coverage. I'm absolutely sure of that. You're very smart, clever people, and you want to do the right thing. The question is, what is the path that is the right one? Is it a sudden big lurch towards Medicare for all, or is it a slow incremental thing that builds on what you have and doesn't frighten the horses, as we say? So you will find that. But the one insight I would leave from my Harkness Fellowship is I went around the country looking at why there wasn't, why there was so many uninsured people, when you have so many smart people, so much research telling you about the problems. And my bottom line was that the social justice thermostat in this country is set at a different level than it is in Europe, in that it was just set too cold. For our liking, and that you needed to dial that up. We needed a war to dial that right up. Maybe Victor Fuchs was right. Short of major civil disturbance or a war, then universal coverage may not happen. But let's hope it will happen incrementally.
Yeah, I would go for coverage as well. I mean, one of the strong things of our countries is that you share the cost with like all the people in the country instead of only the people who have insurance. And when insurance rates go down, prices, I mean, the premiums for those people who actually are insured obviously go up. So that will be one of the things with the price controls. And I think I would look at primary care system, because I feel that in both of our countries there is a very strong primary care system. And the primary care doctors in our countries, they are trained outside of the hospitals in primary care. That means they really have a different mindset. They have a different mindset than the specialists in our country. So the primary care doctors, they look at the patient as a person. Look what's needed, what's not needed. They have the discussion on what's appropriate, a lot of shared decision making. And I think that also contributes. I mean, we in the Netherlands, we're quite resistant with, we don't prescribe a lot. I mean, that's a large difference, I think, also culturally with the US, is that we tend to like see what happens, watchful waiting, and not just do all kind of treatments. And yeah, I would love to see a bit of that mindset here in the US, but I think that's like a large change.
Okay, we have time for one more question. Right over here. Right there, yeah.
Hi, I'm Inmi Song with the Lloyd A. Fry Foundation in Chicago, and I'm really interested to hear about your work in the integrated care. We're working with federally qualified health centers in Chicago to try to help them with that practice. You didn't talk about integrating mental health care and behavioral health care into the primary care, and I'm interested in your experience there.
Yeah, so I briefly mentioned the specialized nurse practitioners on mental health care that are now in every primary care practice. So they are the first point of contact, and they work together with the primary care physician. And only if they together think, okay, this patient really needs specialized care, they refer to a mental health care institution. Frankly, our integration between behavioral or mental health care and like non-mental health care at the specialist level could be better. I think we're pretty good at primary care level, but not so good at the specialist care level.
I think it's that's very similar in the UK. And when you look at all the disease clusters, particularly for people with multiple chronic disease, the commonest factor between them all is some kind of mental health problem, often depression actually. Now what comes first is not clear, and we have recognized that we need to do a lot more to have dual sort of attention on both mental and physical illness. And for example, I mentioned waiting time targets earlier. We've now got waiting targets for people in mental health as well, so that before it was just elective surgeries. That doesn't really answer your question, but I would say we're on it, but we don't do it very well yet.
Okay, I think we're done with questions. I just want to make one last short commercial for the Commonwealth Fund. If you go to our website, you can find descriptions of virtually every high-income healthcare system in detail, every question you might want an answer to. You'll also find our Mirror report, which compares 11 high-income countries in detail on their performance on multiple dimensions. So feel free to access additional information beyond what we shared this afternoon. Thanks to our panelists.
Thank you.